كويس، حلينا المشكلة من غير عراك. حلينا المشكلة من غير عراك يعني ولا حاجة. Thank you very much.
دكتور عم بليز.
اتكلمت على الكلاسيفيكيشن لو متابعين تو هاي كلاسيفيكيشن. Sometimes the base say less than 10, less than 8. High risk or low risk existing?
Is a high risk.
Irrespective of base A.
Oh, exactly. Any one of the three criteria classification into its category. That means 8 or higher is a high risk, whatever the clinical stage it is. If you have picked it very early with a lesion of 9, that this patient is a high risk patient, regardless of any other.
So we'll move to the third topic this afternoon, which will be on the metastatic hormonal sensitive prostate cancer, and also we have two talks. The first will be by Professor Hisham Al-Ghazali about the chemotherapy change, if chemotherapy would change your practice to save more lives. Then Professor Tariq Osman will give a talk if the hormonal therapy is enough or not. So Professor Hisham.
Thank you very much. Excuse me, Mr. Chairman, I'm asking Professor Tariq to join me to try to define SAD-5 from here. So I'm very happy to have these hot topics and very happy with the lecture with Professor Mohammed Kamal and Dr. Samir Azazi, Dr. Ahmed Salim. And I'm very happy to start this NDT here, and I hope next year to be more and more active. We'll talk about the metastatic castrate-naive prostate cancer, and with adding chemo to save more lives. And we know that the prostate cancer is the second most common cancer worldwide. About 700,000 new cases per year. Egypt, fourth most common, as National Cancer Registry said. And here is most important key points: the life expectancy of the people with better life. We have now what is called silver tsunami, and by the year of 2030, we have one of every American more than 65 years of age with better life expectancy. This is very important when you choose your treatment to save more life and to look for the overall survival. And this is the natural history of the disease in stage 3 and 4. Going to hormonal treatment, 80% responding and 20% failed, and who are responding, the median duration of response is about 3 years. And going to the refractory phase with the median survival about 6 to 12 months only. Here are the results of androgen deprivation therapy with the median survival by the using of LHRH analog or the using bilateral rotatomy of about 30 months of median duration of overall survival, about 30 months, and maybe increased by the intermittent androgen deprivation therapy or continuous androgen deprivation therapy to about 49 months. You are satisfied with this? And then going to the more important, crucial point, which is the heterogeneity of the tumor. And this is the hypothesis that we may have androgen-independent cell and androgen-dependent cell. This is the hypothesis. This is the cartoon. What was actual? This is the histology, the immunohistochemistry, and the FISH. We have already androgen receptor sensitive and androgen receptor negative, positive and negative inside this. So we have already the problem. We have already the heterogeneity, not only in the pathology but also in the imaging. So the same patient, heterogeneity. So in the PET scan with FDG, you have some metastatic lesions, and in PET scan by other modality, the NAF, you have another lesion, heterogeneity inside the patient. If there is anything in the future we may go for, how to personalize, yes, the circulating tumor cell, what is called the androgen receptor V7 circulating cells, we can detect and predict the response to androgen deprivation therapy. So can we go for combination treatment? Are you succeeding in the combination therapy in oncology? Yes. Combination between chemotherapy and each other in germ cell tumor, Hodgkin disease, and non-Hodgkin lymphoma, head and neck tumors, radiation plus chemo, surgery plus chemo in core and breast, hormonal plus local radiotherapy in prostate and breast cancer. So this is the hope, to give combination affecting the androgen responsive and the androgen non-responsive or independent cell, leading to better outcome. This is the docetaxel with hormonal sensitive disease. The famous charted trial, Professor Sweeney published in New England Journal 2015, randomized the patient either to receive hormonal androgen deprivation therapy with or without docetaxel, about 400 patients in every arm. And look to the results. I want you to imagine with me that these results and these figures is like an individuals, persons, maybe your father, my father, someone. So you have 82 deaths only in the chemotherapy and the androgen deprivation therapy arm, and 110 deaths in the androgen deprivation therapy arm. So you are saving 28 lives. It is not figure. And this is the patient characteristics. Most of the patients are 65 years of age, performance 0 to 1. And look to how beautiful the overall survival curve separated here. And also, because one of the criticisms, Dr. Tariq said to me now, that maybe this is the effect of the further treatment. And here, the time to castration resistance, a very good separation here with a very good hazard ratio of 0.252, and time to clinical progression, symptomatic or radiographic. I'm very impressed by this separation. Hazard ratio 0.43, and the improvement with docetaxel in all subgroups, and no gain without PIN, as you usually said. Only 3% probability of febrile neutropenia. Conclusion: we must combine. Your turn.
Thank you, Dr. Hisham, for this presentation, and thank you for this invitation, of course. And it's my turn to fight you. Of course, Dr. Hisham actually screwed my brains over the last week, so I'm trying to get my revenge now. First, I'd like to share with you a moment of silence with our victims in the last night's tragedy. May God bless their souls. Okay, now I'm going to talk about a typical oncological subject. Unfortunately, I am actually a surgeon, and this is one of the most difficult tasks I've ever been exposed to, and I'm now going to try to take off my scrubs and wear a white coat and talk as an oncologist, which is very difficult. I hope I'll not disappoint you. What about the hormonal versus the chemohormonal treatment in metastatic prostate cancer? Well, we have been taught and we learned that the basic treatment for hormone-sensitive prostate cancer is androgen deprivation. Very long time ago, since Mr. Huggins discovered this Nobel-honored discovery in 1947. And since then, we have been treating these patients with androgen deprivation treatment till now. And there are several, maybe hundreds of studies that have reached the conclusion that androgen deprivation therapy is the optimum treatment for hormone-sensitive cancer, with an approximately 5 years overall survival of 75% and a 90% 5 years cancer-specific survival approximately. And it has been established also in the guidelines. This is an example. This is the European Association of Urology guidelines. And as you can see, for M1 patients, the level 1 evidence treatment is castration, and the one, of course, with the grade A recommendation. So what happened over the last decade? As Hisham said, we discovered a very, very important molecular fact, that there is a tumor heterogeneity, and this paved the way for seeking better successes with adding chemotherapy over the hormonal therapy, on the assumption that there are some androgen insensitive cells in the prostate cancer tissue. But what is the actual clinical interpretation for that? We have these facts that chemotherapy actually improved survival in a very, very difficult situation, which is the castrate-resistant prostate cancer. This is the important fact. And the second fact, that we found that adding chemotherapy to those patients who are already on androgen deprivation therapy did better than if you stopped the androgen deprivation therapy and give them only chemotherapy. So there is some suggested synergism between chemotherapy and androgen deprivation therapy. So these two factors led to the very important study that has been mentioned by Hisham a few moments ago, which is the CHARTED study. And this CHARTED study is a positive study that proved that it's a randomized study on 790 patients that proved that there is a survival advantage of adding chemotherapy over hormonal therapy or over androgen deprivation therapy. And actually, it gave the patient a 13 months plus 13.6 months additional survival advantage over androgen deprivation therapy alone. And of course, as Hisham said also, there is an improvement in median time through biochemical progression, etc. There is rate of prostatic specific antigen level increase is better with the combination. However, let us dissect into this trial a little bit and see some important points that should let us interpret the data with caution. First of all the patients in this population studied were all of a very good performance. The ECOG performance score in all the patients was 2 or less. This is number one. Number two, those patients who received prior adjuvant androgen deprivation therapy prior to the study were not excluded. So some of these patients were actually on androgen deprivation therapy before randomization. So this is an important thing to consider, that there is some selection problem. And even patients who had received up to 4 months of androgen deprivation therapy before the study were actually also included in this randomized study. And again, and the most important observation in the study, there is a quite important difference between the survival advantage on patients with high volume disease versus those with low volume disease. What is a high volume disease? A high volume disease is defined as the presence of a visceral metastasis or more, or 4 or more bone metastatic lesions. And one of these should be beyond the vertebral metastasis. So this is what we call a high volume metastatic disease. So this is the beautiful graph that Hisham showed you, that showed you the overall survival on the Kaplan-Meier survival is better, but this is the one that he hid from you, that the survival of both cases, of both arms in low volume diseases were not statistical significance, are almost the same. And surprisingly, the adverse events in the CHARTED trial was much less than expected. And then came a very negative study, which is the JET UG study, which even antagonized the study of the Charter trial. And this has been published in the Lancet Oncology. And they said it was also an open label study, randomized, 29 centers shared in this study, and none of the patients, and this is more important, this is what makes it a little bit better than the Charter trial, that none of these patients actually received androgen deprivation therapy before inclusion in the study. And look what they find. There was no difference in survival between patients who had androgen deprivation therapy alone or had androgen deprivation plus chemo for hormone-sensitive prostate cancer. Then the median overall survival was 58.9 months in the group who had the combination, with the 54 months with the group of patients who had only androgen deprivation therapy. That's to say there was no statistically significant difference. And they also reported 72 serious adverse events were reported in this group in patients who had both the combination therapy. So what can we get from these two trials? Docetaxel plus androgen deprivation tissue, if beneficial, would be only for patients of high volume disease. And as I said, high volume disease are actually, let us talk in our clinical practice, these are the usual 4 patient types that we have, either a patient with low volume disease, or low volume metastasis, or a moderate volume metastasis, or a patient with a high volume metastasis and good performance and good chemical profile. And the last category is a patient who has a high volume metastasis, poor performance, and bad chemistry. These are the usual classic examples that we have faced in practice for metastatic prostate cancer. I want to ask you all a question. Who do you think will be suitable for a combination of chemo and hormonal therapy, and how much of these patients actually are present in our real life? These are the only group. And let us ask ourselves, how many of these group do we actually meet? You find a patient actually with a high volume disease, that means more than 4 bony deposits and a visceral metastasis, and you still find them in most of the time, are the performance, is this okay? Do you have usually a chemical profile? Don't they have most of the time a locally advanced disease as well, and bilateral ureteric obstruction and renal impairment? Come on. So I think I will leave you with this slide. Thank you.
Thank you.
Try to affect you emotionally, but I will give you the data. So we will rely on all these points. The Stampede, coming with me. So a huge study, the Stampede study. All the metastatic disease, no high volume or low volume, the volume is not included. So the metastatic and not positive, and both with more than two or more of the stage 3-4, BSA equal or more than 40, Gleason's 8 to 10, and also those patients relapsing after previous radical prostatectomy or radiotherapy, and all patients must be fit for all protocol treatment and fit for follow-up. And the primary endpoint with this very important Stampede trial is the overall survival, saving lives. Don't look to the cartoon. The lives is more important. So the secondary endpoint is the failure-free survival, toxicity, quality of life, skeletal-related events, and cost-effectiveness. And this is the definitions, multiple definitions. Started with 6 arms with the celecoxib removed, so the remaining 4 arms. Standard of care, which was androgen deprivation therapy with zoledronic acid, with docetaxel, and with zoledronic acid and docetaxel. And this is the number of patients involved in this trial. You see here, about 1,100 patients in the androgen deprivation therapy, the standard of care, was the standard of care, and patient with about 600 in each arm with zoledronic acid or docetaxel or both. And here are the patient characteristics. We are going to the details to be sure. These are the patient characteristics. Metastatic disease, about 61% of the population. And also the patient receiving LHRH analogs, about 89%. And look here for the failure-free survival. Again, how beautiful the survival curves here. And look for the survival. And I'm giving you the facts, not the cartoon now. Look to this. Look to the difference. Look how you save lives by adding chemo to the hormonal treatment. 165 deaths only with chemo compared to 405. If you go for airplane accidents, you may do more than this. So, please, save lives. And here, again, the chemotherapy with even zoledronic acid giving better result than the standard of care in survival and disease-free survival. And here, the analysis subgroup in metastatic disease and overall and non-metastatic disease, either in overall or in disease-free. And here again, for the metastatic patients only. So I know that Tari will said you it is heterogeneous. This is the curve in metastatic disease. And also again, there is no gain without pain, some side effects with chemo. And lastly, this is the meta-analysis, bringing the French trial, which was negative and published in Lancet, and here the charted, the Stampede, and this GTUG trial, and the results, there is improvement in survival with the addition of chemotherapy. This is the guidelines. The NCCN guidelines in 2016, men with high volume androgen deprivation therapy naive metastatic disease should be considered for androgen deprivation therapy and docetaxel. Again, the ISMO guidelines 2015, androgen deprivation therapy plus docetaxel is recommended as first-line treatment for metastatic hormonal naive disease in men fit enough for chemotherapy, level 1 evidence. Thank you. Please save lives.
I would like to thank both speakers for this nice debate. I'll just add, sorry. Okay.
Okay. The Stampede trial. Yes, the Stampede trial came as a rescue for people who are devoting and suggesting chemo-hormonal therapy. I wouldn't argue that, but again, let us look in between the lines. First, the first contradiction, the Stampede trial, yes, gave an overall survival advantage over hormonal therapy, but it was less than the charted. Something happened here. Why? Why was the Stampede trial less in result than the charted trial? 2. Again, let us look at the patient criteria. The Stampede trial was not for our main topic. Our main topic is hormone-sensitive metastatic prostate cancer. Only these constitute 60% of the Stampede patients, while 40% of the patients in the Stampede trial were not hormone-sensitive metastatic prostate cancer. They were either locally advanced or high-risk patients who underwent local therapy. So there is a very big question mark about contamination of the population here. 3, the Stampede trial proved that zoledronic is a failure in regarding survival. So these are the first 3 marks about the Stampede. So I would agree there is a benefit of docetaxel over when it is added to androgen deprivation therapy in improving overall survival. But this is not the question. What about castration resistance after that? What about these patients who you from the start, you gave them docetaxel and hormonal therapy? How are these patients that you rescued all your weapons to them? Are these patients will remain docetaxel naive as the counterparts who had only androgen deprivation therapy and then move to castration-resistant prostate cancer? This is the important question, when to give the chemo. We all know that in castrate-resistant prostate cancer, docetaxel gives us a 6 months life advantage. Will this remain the same after giving this patient 3 years of docetaxel and androgen deprivation therapy? I doubt it. So the question is not to give docetaxel with androgen deprivation therapy or not. The question is when to give it. Upfront with the androgen deprivation therapy or delayed after castration resistance. Unfortunately, this question is not answered specifically in the STAMPEDE and the CHARTER trials. So what we need is a study that prospectively designed to answer this question, to randomly divide 2 groups of patients, similar characteristic. One group will go through androgen deprivation therapy, wait until they got castrate resistance, and then give them docetaxel, while the other group do as the STAMPEDE and CHARTER did, start from the start with androgen deprivation therapy and docetaxel, and continue this regimen when they are castrate-resistant prostate cancer, and then finally check the survival. If this happens, definitely we will go for chemo and hormonal therapy as a first line. Until we answer this question, we could consider only and not more than consideration, because there are other important factors to consider. We have to consider the cost of adding chemo or chemotherapy to the androgen deprivation, and we have to consider the side effects. We have almost 52% grade 3 to 5 adverse events happened in the STAMPEDE trial from docetaxel. So these are 2 important factors that should be considered. So what about the take-home messages that me and Hisham have reached? Chemohormonal therapy should be offered to patients with high volume hormone-sensitive prostate cancer, provided they have a suitable performance and suitable chemical profile. Others could be counseled individually about risk on cost over benefit. And we need more studies are needed to verify this data, specifically after these patients develop castration-resistant prostate cancer. And I believe we should strongly advocate a multidisciplinary practice in our country. Thank you very much.
So, any questions or comments? Yeah, please.
Enjoyed teamwork actually between the surgeons and oncologists. 3 comments. Number 1, one of the oldest and actually leading randomized clinical trial for locally advanced prostate cancer, published in Journal of Urology 1995, with lead author on it, myself, Abdulaziz Al-Gamal. It showed a survival advantage for patients who received estradiol phosphate, which is a combination of estradiol hormonal therapy plus estradiol phosphate. And the 10-year disease-free survival for that population was locally advanced prostate cancer, so-called now high risk, was 78%. 78%, that's right. Number 2, regarding the androgen receptors, actually they are divided into 3: androgen sensitive, androgen insensitive, and what's between is the androgen independent. The androgen insensitive actually would be repressed. I mean, it would be activated after hormonal therapy, and that's why, because we have 3 different heterogeneous population of cell receptors, it's better to combine it, but also to combine it with the surgery. This is the main advantage. I mean, to have neoadjuvant, downstaging, combination of whether docetaxel, I guess Logosides from MD Anderson published that too more than 15 years ago. Docetaxel plus hormonal treatment, but my own experience with estramostim as a combination of chemotherapy, estradiol plus estradiol, estracid so-called, which is available also in Egypt, of course with cardiovascular events that should be avoided by aspirin and things like that, would provide the highest 10-year disease-free survival in a randomized study. Again, go back to Journal of Urology, 1995. It was somewhere in October. The last comment actually about the metastatic, whether chemo-naive, hormonal-naive, I believe that we need to separate between lymphatic metastasis, which is M1A, as compared to bone metastasis, which is M1B, and of course M1C, which is liver metastasis or abnormal site of metastasis. How to handle biphosphonate with ursolithronic acid, denosumab, or radium-223 is a drug of choice or treatment of choice for patients with M1B, bone mets. As compared to the hormonal treatment, we don't give any chemotherapy for patients with bone mets. So combining docetaxel for patients with mets, what mets? Bone or lymph nodes? Of course, docetaxel would work for lymph node, metastasis, M1A, so-called, but will not work for M1B. So adapting myself to the IGILUC now, I think we need to make a study worldwide to separate between people from the region with bone mets, lymph node mets, or somewhere else. Like I have seen and have treated patients with liver metastasis, which is classified as 1C. And I'm trying to push myself.
So it's very. Thank you very much for this very important comments, but it's very, very extensive. And you know, I don't like to violate the program. And you know that we have about 1 hour after this session to discuss these issues. So we have a huge MTT here from the oncologists and urologists to answer this. And the go for light, we tried, we hope, to go for light special combination with Brazilian here also, and help us. So it's important to answer all these questions in a statement between the oncologist and urologist. But if we will answer now, we will violate all what we will give in the next lecture. Thank you very much.
Thank you very much for this very nice debate. And now we'll move to the last speaker today, will be Professor Dr. Ahmed Hamada, who will talk about selection and sequence of treatment in metastatic castrate-resistant prostate cancer.
Thank you, Chairpersons. First, I would like to thank Professor El Ghazali and Professor Samahita for their kind invitation. Definitely, my talk will be very difficult about treatment selection and sequence in castrate-resistant prostate cancer. This is my disclosure. And as you all know, that we have definitely a revolution in the treatment options for prostate cancer after 6 years hiatus from the year 2014 to the year 2010, where we have the docetaxel in the year 2004, and thereafter we have a lot of drugs, approximately 5 drugs, which improves the overall survival in castrate-resistant prostate cancer. So this rapid change definitely have left many unanswered questions how to have the optimal selection to your patient and the sequence of therapy. And this is a natural history of prostate cancer, ranking from local disease till the castrate-resistant or castrate-sensitive with whatever your patient is symptomatic or asymptomatic, and definitely metastatic or not metastatic, and definitely the performance data should be taken into consideration. However, definitely with ADT, we have intrinsic resistance, which can occur, and this due to the androgen-dependent and the androgen non-dependent and even the androgen insensitive and sensitive, and this will lead by the end to a castrate-resistant prostate cancer. However, the overall survival in metastatic hormone-sensitive prostate cancer by nadir of PSA is quite different. If you have a PSA of more than 4 nanograms per ml, definitely you have lesser survival than if you have a PSA in the range of 0.2 nanogram per ml. And as mentioned by the previous speaker, Professor El-Ghazali and Professor Tariq Osman, that if early chemohormonal treatment will benefit in the castrate-sensitive prostate cancer or not, we have the pros and cons. And definitely it should work, the chemo, because it kills the de novo ADT-resistant clones early, and this should allow a longer remission with ADT. But on the other hand, definitely you have some patients that progress and becoming too frail for chemotherapy when castrate-resistant prostate cancer develop. But it won't work, the chemotherapy, as ADT will take the cells out of the cycle when less responsive to cytotoxics, and no combination therapies have been shown to prolong overall survival in metastatic castrate-resistant prostate cancer. We have only that chemotherapy docetaxel acts well, but we didn't combine docetaxel with hormonal treatment in metastatic castrate-resistant prostate cancer. And because of this, we have one trial in the hormone-sensitive, the GETOC 15, which is a negative trial. It shows only an improvement in the biochemical PFS and clinical PFS. However, the overall survival was negative. And came the CHARTED trial, which was very well discussed and showed an improvement in overall survival, especially for those patients with high volume disease. However, the STAMPEDE, again, with the pros and cons against the role of inclusion and the types of criteria that patients include, we have definitely a criteria that STAMPEDE addition of docetaxel to standard of care improves the overall survival despite the highest grade 3 toxicity. So what about the castrate-resistant prostate cancer? A long-standing program since the Nobel lecture at the 1966 by Charles Hagens, that despite regression of great magnitude, it is obvious that there were many failures of endocrine therapy to control the disease. And this is the EUA since the year 2011 doesn't change, that we have serum castrate levels of testosterone less than 50 nanogram per ml, 3 consecutive rises of PSA 1 week apart, resulting in 250% increase over the nadir with a PSA more than 2 nanogram per ml, and definitely you should have an anti-androgen withdrawal period for more than 4 weeks for flutamide and for more than 6 weeks for biglutamide. These are what being tested in first-line castrate-resistant trials. We have at least 6 drugs starting by the mitoxantrone, docetaxel, abi, and sipilucel, enzalutamide, and the radium-223. While for the second line, we have again from the abiraterone, enzalutamide, sipilucel, radium-223, and we add the cabazitaxel and the ipilimumab and the orotoronel. Definitely, it is very nice to have these 5 drugs that leads to improvement in the overall survival in castrate-resistant prostate cancer, starting by the abiraterone, enzalutamide or Xtandi, radium-223, cabazitaxel, and don't forget the sipilucel T. However, we have many open questions. The first one, should we really sequence all these treatments, and what about the cross-resistance among these drugs? And the sequencing into pre and post docetaxel spacing has been blurred because we have now 3 agents, the radium-223, the abiraterone, the enzalutamide, that have shown a survival benefit whether we use it prior to chemo or after chemo. And also, we didn't have any one sequence that can be endorsed over any other at this time. And the trials will never address all the alternatives, and it doesn't give the huge number of potential options. And also, it is not clear how long the field will remain in a sequencing paradigm, and the need for evidence for combination therapies and definitely better patient selection. However, treating patients with multiple drugs is definitely correct, but we are still definitely have no data to support such a strong view. These are very retrospective phase 2 studies where we have the abiraterone, post-enzalutamide, and post-docetaxel, one European, one in North America. And as you see, you have the PSA decrease more than 50% in the range between 3 and 8%. And you have a median PFS in the range of 2.7 months to 4 months. And you have only one partial response in the European trial and no objective radiological response in the North American trial. Concerning the enzalutamide post-abiraterone and post-docetaxel, we have 3 phase 2 trials with a PSA decline of more than 50% in approximately ranging between 10 to 20%, median PFS in the range of 3 months, and median overall survival approximately of 7 months. Concerning the taxanes post-abiraterone and the cross-resistance, we have docetaxel and cabazitaxel. For the docetaxel, we have a PSA decrease of more than 50% in 26%, and the median overall survival of approximately 1 year. While for the cabazitaxel, we had a 39 PSA decrease of more than 50%, median PFS of 4.6, and the median overall survival of 15.8. So the issue is what happened? Do we have any cross-resistance that can occur when we use Abi-Enza, or what happened if you didn't have any cross-resistance? So cross-resistance, yes, it is proved that we have cross-resistance when we compare from one agent to the other, and the responses, as you see, is very minimal concerning the PSA decline or even the PFS. And although formal studies are lacking, we give all these data from retrospective small studies, including small number of patients, and taking together all this data, definitely we should have a cross-resistance between Enza and the abiraterone when these drugs are used sequentially. However, we have a very elegant paper that stated that cabazitaxel remains active in patients progressing after docetaxel, followed by novel androgen receptor pathway targeted therapy, where in a retrospective, again, analysis of 79 metastatic castrate-resistant prostate cancer, they have a PSA response for more than 50%, 35%, rises to 62% for the 30%, and the median PFS of 4.4 months, and median overall survival again reaching to 1 year after using either androgen receptor antagonist and the docetaxel. The second question, can we predict which patients benefit from subsequent to hormonal manipulation? From other the clinical parameters, we have the duration of response to prior ADT, predicted the benefit from subsequent endocrine therapies. As you see, yes, if more than 1 year, you have 41% PSA response versus 16%, and by the duration, the PFS also you have 6.6 months versus 3.2 months for those taking ADT for more than 1 year. Docetaxel activity by duration of first-line ADT, definitely it acts that if you have the combination of docetaxel prednisone versus mitoxantrone, definitely overall survival and PSA response by the duration is much better when you use the docetaxel prednisone versus mitoxantrone prednisone. And does the Gleason score predict for treatment whether taxanes act in both low and high Gleason score, abiraterone in both low and high Gleason score? They answered that Gleason score unlikely to help decision making in metastatic castrate-resistant cancer. Does baseline androgen level predict for efficacy of new generation endocrine therapy? Again, definitely serum androgens unlikely to help the decision making in metastatic castrate-resistant cancer. However, we have an elegant but complex way to identify patients who benefit from Abi, where definitely those responding to abiraterone, which are identified as patients ongoing on the drug for more than 4 months, they go for bone marrow biopsy and assess the AR nuclear expression and the CYP17 expression and classify the patients into responders and the non-responders. Also, we have the AR splice variant, which definitely the ADT induced constitutively active splice variants, and we have 2, the AVR567, which counted in 43%, and the ARV7 in 24%, and these contribute to resistance to both endocrine agent, the Enza and the abiraterone, due to the lack of the hinge and the lack of the domain that act against this target. Also, these are the predictor of AVR7 in very small 2 trials, including 31 enzalutamide and 31 abiraterone. As you see, if you have a positive, it definitely goes to the lack of activity of this enza and the abiraterone. Also, we have the glucocorticoid receptor overexpression, which again is associated with clinical resistance to enzalutamide. Can we predict which patient benefit from immunotherapy? Definitely, we have the ipilimumab, which is an anti-cytotoxic TLA agent, checkpoint inhibitor. Post-docetaxel phase 3 study, overall survival was not quite comparable. It reached just a p-value of 0.05. However, when we go to patients in a better conditions, definitely those with alkaline phosphatase less than 1.5 of the normal, hemoglobin more than 11 grams, with no visceral metastasis, we see a median overall survival of 22 versus 15 for the placebo. So the last question, can we predict which patients benefit from radium-223? We have some data that definitely alkaline phosphatase could be a predictor of radium-223, where we're going for substratification. Those patients with more than 220 alkaline phosphatase benefit definitely from the addition of radium-223. So finally, what does the patient think about this area of increasing drugs? We have the CABA-DOC phase 3 study. We're assessing the patient preference between docetaxel and cabazitaxel, and this is under accrual. So the treatment sequence should be depend whether you have symptoms or not, whether you have chemotherapy before or not. And as you see, for metastatic asymptomatic chemo-naive, you can go for Sipuleucel or Abi-Enza. For metastatic symptomatic chemo-naive, you can go for docetaxel, abiraterone. For metastatic post-docetaxel, we have nowadays the Capazi and the old mitoxantrone and the abiraterone and the enzalutamide. And please don't forget the bone targeting therapies. That denosumab definitely to 18% risk reduction of skeletal-related events. Then zoledronic acid, however, they didn't have any impact on the survival. So definitely we should optimize our patient selection. However, we have pitfalls that none of these newer agents have been compared one to the other. And definitely because of this, we didn't have any level 1 evidence for treatment choice until there are head-to-head trials. And predictive markers should be tremendously helpful as they are currently now accepted in the general clinical practice. And currently, the evaluation of the initial treatment of metastatic castrate should be focused on 2 aspects: the disease burden and definitely the patient performance status, chemistry, as mentioned by the previous speakers. Again, if you have a patient with no visceral disease and relatively slowing PSA, asymptomatic or minimal symptoms, the initial therapy with Sipuleucel is reasonable. However, we have 2 phase 2 studies combining the Abi and enzalutamide to the Sipuleucel T. Also, if you have bone disease, you can go for radium-223. However, if you have a patient with single bone lesion, it may not show the maximum benefit from the radium-223. Also, again, if you have visceral involvement, we have level 1 evidence that support enza and docetaxel versus abiraterone, which is not commented. The predictive, we have nowadays the PARP inhibitors, the olaparib, which act again as the BRCA2 mutation and show definitely better response. And by the end, we have 4 families of active agents, and we need to learn more about how best we use them. And by last, we definitely have a lot of drugs that act, but we didn't reach a level 1 evidence about the sequence. And definitely by the personalized cancer care in prostate cancer, we are ready now to have more and more future trials comparing head-to-head enza, Abi, and different agents. And thank you very much for your attention.
Thank you, Professor Ahmed, for this elegant lecture. It's a lecture. Okay. Do we have any questions? Okay.
I enjoyed your talk actually, and I wonder what's the status of the prostapac as immunotherapy, the tyrosine kinase inhibitor, and the electron kinase inhibitor, and lastly the ketoconazole at the dose of 1200, which no patient would afford.
Definitely. I didn't know the vaccines. You talk about vaccines. Definitely yes, because we are in the era of the immunotherapy and it is growing nowadays, but we didn't attain. Even the single cell didn't have the prevention. And it is very costly. And I think the combination of abiraterone or the enzalutamide will replace such very expensive, costly drugs. Concerning the tyrosine kinase, we still have no phase 3 data on the tyrosine kinase in the management of prostate cancer. But I think we have more data about the phase 2 trials that we have improvement by tyrosine kinase inhibitors.
Actually, everolimus, I have experience with using everolimus as mTOR kinase inhibitor, whether orally or intravenous weekly basis, that reduces the PSA by more than 50% in our population. With regards to immunotherapy, I also was one of member of a team who was working on development of the dendritic cell vaccine, the CPLC, and that was has improved survival in asymptomatic patients, as I just mentioned. So again, it's time to make a solution for this very wonderful conference and presentation. Thank you.
Any more questions for to Dr. Ahmed? Okay, thank you very much. Thank you. Thank you all. And thanks for my co-chairperson. And thank you.